Good afternoon, everyone. As you come in, if you wouldn't mind muting yourselves, please. And in the meantime, as we wait for everyone to join, if you wouldn't mind introducing yourselves in the chat by letting us know where you are joining us from, we would love to hear from you all. Right. And then I think everyone has gotten a chance to join. Just waiting for a few folks in the waiting room to connect to audio, and then we will get started. Hello, Julie. Thank you for joining us. Hi, Linda. Continue to introduce yourselves in the chat and letting us know where you are joining us from, and then we will get started. All right. All right, so during this session, I will go ahead and monitor the chat as well as the waiting room. But welcome to our presentation, Linking Data to Prepare. Thank you all for joining us. I will now pass things over to my colleague, Ray, from the Clinical Affairs Division, who will take us through this presentation.
O sea, como que no le dan
Ray, the floor is yours.
Yes, thanks so much, Chloe. Good morning and good afternoon, everyone, and thank you for joining this session entitled Linking Data to Prepare. I see we are joined by a multitude of people from across the nation, all the way from College Station, Texas, from Utah, from Florida, Georgia, Indiana, Kentucky, North Dakota, Montana. Thank you so much, everyone, again, wherever you are joining us here today for this session. And I'll go ahead and get started. Thank you again. So on the next slide, let I remind you that we are the National Association of Community Health Centers. Yes, we are America's voice for you guys. Thank you so much for all the work again that you guys have been doing.
Johnny.
Next slide. These you will see on the next slide of the pillars of NAC. Yes, all the way from equity and social justice, infrastructure, all the way to supportive partnerships, and that's why we have these sessions. Thank you again. Let us begin. All right, today, these are our learning objectives. First, to review clinical data standards, terminology, and policy. Two, to discuss the importance of linking data to prepare. And the third, to understand how these data standards and structures relate to the everyday workings and your everyday activities as community health center staff. So to begin on the next slide, it's very difficult to really talk about Z codes and talk about linking data to prepare without really talking about standards. And you'll see this here in one of these questions previously done by our prepare team, which is in a sentence, describe why would you like to leverage prepare data to respond to social needs? And what I've highlighted here, right, somewhere in the middle column, right in the middle, highlighted in red, the response was, I would like to hold EMR vendors accountable for making these workflows as easy as possible for CHE staff so they can spend their time with patients and not on double entry in documentation. I 100% believe that. And that's where we're having this session also. On the right-hand side, you'll also see another statement that they want to learn how to use prepare data to inform risk stratification. And that
what is this supposed to go up?
do all this risk stratification, you have to understand data standards and clinical data terminology, which is what you will see in the next couple of slides. So we all speak different languages. I speak two, some speak one, some people speak multiple languages. And I wanted to begin with this because standards, clinical data standards or data terminology are there to make your software and to make computers speak and understand each other in the same way that if I don't understand your language, I might not be able to understand what you're telling me. In the same layer and data has to be represented using standards so that other software can understand the meaning or the regular data that's inputted by you guys when you're capturing prepare data. Next slide. So standards. You might think that standard, what are those? It's kind of boring, or I don't really understand what they are. Standards exist on our day-to-day activities. The moment you use your credit card, the moment you use money, and the moment you start streaming your videos and audios, all of those are using standards to make sure that your content gets streamed to your cell phone, gets streamed to your laptop, gets streamed to whatever operating system you're using, whether it be Mac OS or Windows. Standards are there to make sure that messages and data come across in a way that is expected by the software. Just like your email, just like your text messages uses SMS, just like when you order something from Amazon or your online grocery shopping.
He had to go and do.
All of those use standards to make sure that your transactions online are work really well, conform to the data standards, and they are usable by any other software. The problem is that this really interesting comic. There are 14 competing standards. That's ridiculous. We should follow everyone, and now there's 15. So that's really the crux of standards proliferation and standards development is we really try our best to make sure people conform to one standard so they understand each other. Just like one side note, the new iPhones are using USB Type-C, which means you won't need a separate connector to connect to your Android and iPhone devices. So that's how standards work. You don't have to find a different cable to charge your iPhone, or I mean, you can just use USB Type-C. In the same way as health data and prepare data is, they have to be using the same standards. Your data has to be captured using the same standards. Next slide. Yes, so as I mentioned earlier, standards are used in all of these services. I'm sure you're familiar with some of these. Next slide. So what's happening right now, I'm sure everybody has seen this, is we're currently in a state of an interoperability nightmare where different electronic health data silos exist in different places. Your registry exists in a different place. Your research data elements are in a different place. Different EHR, it's housed either locally or in the cloud. It's everywhere. Our future vision is really to have something seamless with semantic interoperability. When I say semantic interoperability, the context and the meaning of the data that you send to another system retains its meaning. And that's very important if you want to aggregate data, such as prepare. Lots of organizations use prepare. The issue is how data is captured and represented in your database. So lots of the times, some prepare data is captured in free text. And free text is difficult to aggregate with other free text or those data that's not coded using the same code. What codes am I talking about? Those are the standards we're talking about. So let's go to the next slide. So currently, sharing data is difficult. Not only some of you might have heard of FHIR or HL7, which is a standard way of transmitting health data. So even the sharing data across different electronic health records software vendors, even the same software vendor, there have been a lot of issues where you can't even share with the same Epic or the same Athena or the same, Cerner instance. Second, sharing different software is not feasible and requires manual intervention. That means if the software is not performing to standards, it won't be able to understand. So you have to do some meddling. Extraction is challenging and labor intensive again because things are recorded in free text. Because all these things are recorded in free text, it's hard to connect to social services, right? It's hard to do it electronically. There has to be a lot of manual interventions that's happening. And I'm sure lots of you guys and other health center staff have to do these things manually. And you ask yourself this question, why can the computer do this for me? That's because standards exist. And that's why we're going to do this and show you how PRAPARE exists in the data standard. Last but not least, software is high. So if they're charging you a lot in your software needs to help reduce your workload and help capture data in a standard way. All right. Next slide, please. So data elements and extraction, data elements guide data extraction and analysis. Oh, I see that there's people have been mentioning their audio issues.
Yeah, Ray, I was going to mention if you'd like to try with your video off, sometimes that works best in terms of your audio. But yes, here and there we're getting some interruptions.
Transition to the Thank you so much. Is this better?
It is better, but it happens here and there. But I will let you know. If you want to try with your video off, sometimes that works best.
Absolutely.
Okay.
Thank you so much. All right, thanks for letting me know, everyone. Just to continue, just for the sake of time, we can skip this slide. What that slide is just, the idea of this slide is just letting people know that different things in the electronic health record are captured even in different ways, such as a drop down, tick box, a smart search, all of these things. The important thing is data, again, is captured using a standard. So next slide, please. So similarly, for example, this is a good example when you're collecting information on contraceptives, for example. Do they write it in the fill in the blank? Is it a drop down box? Is it a checklist? Is it a radio box? What is important is what's behind this form. The barrier method, sterilization, and abstinence, does it use or conform to clinical data standards that represent that concept of barrier, concept of abstinence, concept of pills, what specific pills the person is using, those things. So next slide. Yes. So this report was released back in 2020 from the National Alliance to Impact the Social Determinant. And they did mention early on that unless data, SDOH data, is captured in a consistent, structured way using, again, standard terminology, they cannot be easily transmitted and or aggregated to make things meaningful when shared with other entities and other settings. For example, if you have a community-based organization addressing homelessness, you would want your data representing homelessness to automatically collect and refer patients for those services. But if you don't use those codes, then things, again, have to be manual. Next slide. So the key opportunities for advancing social drivers of health data interoperability, again, is to use common data elements and the value sets that contain those codes and those standard terminology codes. FHIR questionnaires, a lot of people are working on connectathons on creating FHIR apps right now. And that's going into policy very soon, as the Office of National Coordinator has an HTA1 proposed rule that requires or mentions FHIR as the data transmission standard for collecting the data elements on the US core data for interoperability. Next slide. So here, we want to discuss US core for data for interoperability because these are the US CDI, as we call it, contains all of the data classes and data elements that are going to be required before the end of the year 2025 for electronic health record vendors to transmit SDO, not just SDOH, but a lot of data elements and data classes. So if you go on Google, type USCDI, you will see a list of classes and data elements on their website. And one specific part of it, part of USCDI, specifically version 3, is called SDOH assessments, SDOH interventions, and SDOH goals. And those all link to data standards, and one of those data standards or collection surveys for methods is PRAPARE. So next slide. core principles of USCDI, it comprises a set of data elements that supports all patients in any facility using a certified health IT product, also known as your EHR, right? It established a baseline for data for sharing to other people and expands and then there's an expansion process where the public can mention that these codes don't work, or I think this data element is very important for people to share. So please, the public is invited to give public comment on USCDR, US Core Data for Interoperability. Again, these are data elements that will require vendors, again, require them to represent data using standards to make it easily shareable, not just to public health agencies, but across institutions and across care delivery services. Next slide. So that's why USCDI matters. If for some of you guys who have heard of meaningful use or the CCDA criteria for transitions of care documents, right? And electronic case reporting for public health agencies, that's what USCDI is. Next slide. We'll go to the bulk of SDOH. Here you'll see that SDOH was included in version 2 of USCDI on the very right-hand side. Goals, assessments, interventions. SOGI is also included, and SDOH problems and health concerns. And as the versions go along, it expands more data elements. Next slide. Yes, and you'll see here the new data elements and classes in USCDI version 3. We're currently on USCDI version 5 comment period, which the deadline is this September 20th. So if you have a data element that you believe is important and that other health centers should be using and capturing this data and sharing it, please go into the website and give us a comment and submit a data element. Next slide. So again, you'll see more of the Z coding and all of that good stuff on the next couple of slides. This is on the Interoperability Standards Advisory. You'll see that different SDOH data elements are here, highlighted on the right column, bound by the red box. Next slide. So we have all these terminologies and codes, but who are using this and who are developing these? On the right side, you'll see that ICD, or the International Classification of Diseases, are managed by the WHO. SNOMED International uses SNOMED. Our version here is called SNOMED CT. LOINC, LOINC, which is for lab data. It's from Regan Street Institute in Indianapolis. And PRAPARE is on LOINC, just for everyone to know. PRAPARE, and each of the questions and answers on PRAPARE is represented in LOINC. Next, we have RX norm for drugs by the National Library of Medicine. CPT coding for procedures hosted by the American Medical Association, and MedDRA, which is for clinical trials for drug representation. You'll see the multi-stakeholder influencers in the very middle here, the NQF, NCQA, and NIST, and the federal influencers, as we know, ONC, the National Cancer Institute, the VAs here, the National Library of Medicine, and of course, the CDC. Next slide. So going through really quickly, these are just basic standard terminologies, and these are yes, you will get a copy of these slides, and it is being recorded. Thank you. All of these standard control terminologies or standards are used across the United States, and a lot of these are also used internationally. So if you want to aggregate your data across outside of the United States, then conforming to these standards will help a lot. Next slide. I think the first one here is ICD-10. Yes, there we go. On the next slide, yes, we'll advance up right there. We discussed this already. On the next slide, you'll see ICD-10, I believe. Yes, these are called billing and terminology codes. As you know, you need your ICD-10 code and your CPT code to get billed and get reimbursed for the stuff that you guys are doing. Next slide. So ICD began in the late 1500s. There's some parish clerks wanted to collect what people are dying from. They called gripping of the guts. They called tuberculosis king's evil. Eventually, epidemiologists and scientists adopted this, and now it's currently ICD-10. Back in 2019, ICD-11 has been released internationally. We are currently on what's called ICD-10-CM, or clinical modification. ICD-10-CM is what the United States uses, and that's where you will find the what's called Z codes. Next slide. this is anatomy of ICD-10 Z code. They're Z codes because they're in the very bottom. Starting if you look at the first image on the bottom, you see Z00-Z99. Factors influencing health status and contact with health services. Z coding. Next slide. And you'll see from Z56, Z55 all the way down to Z65 are the kind of core content for social drivers of health data elements. You'll see that it has specific definitions here. That's why there's lots of codes here with lots of granularity. The biggest issue you'll see in other slides is that the Z coding is very low. And we all know, I think one of the major contributing factors for low Z code use is that just having a Z code is not immediately reimbursable, or not if you collect SDOH, for example, sometimes SDOH screening is not reimbursable depending on where you are in the country. And again, Z codes are usually gets accompanied by a primary diagnosis, primary ICD-10 diagnosis. So I get this question a lot. They ask question, can I put multiple Z codes? Yes, you can. Do I need to be a provider, a physician to collect to do SDOH screener and to do Z coding? Unfortunately, you have to be a medical provider, a licensed provider, to put that in the record, but it doesn't mean that you can't collect that information already, ready for your provider to do the coding. Next slide. Yes, so you'll see that image on the next slide. This image right here is from the CMS. You guys have probably seen this already, from the very first step of collecting SDOH data, documenting it, mapping it to Z codes, using the Z code data, and reporting the Z code data findings. This all won't work if Z coding is not being done. And Z codes are linked to PRAPARE. And there, if you go to the PRAPARE website, prapare.org, you will find a documentation form there, or document you can download. You will see which Z codes correspond to which PRAPARE questions and answers. You'll not only will you see Z codes, but you will also see SNOMED CT codes. These are more kind of granular, more actionable codes with meaning, because SNOMED is what's called an ontology. An ontology means each part of that categorization has a meaningful relationship with another code, unlike Z codes where it's just a basic hierarchy or taxonomy. Next slide. So we already know that lots of people can really use the information or data you get from Z coding. Your administrators can see or track if the data is being gathered. Your care team will be able to action on the Z codes by calling or coordinating with their social worker to connect with their CBO, and also coding professionals if you want to maximize your coding or billing. And once Z coding and SDOH screening and assessments become more billable, then it will help you guys as well as your coding professionals to maximize your reimbursements. Next slide. Thank you for that question, and I want to address it real quickly. Because there are recent annual releases of the controlled terminologies, we will update the current crosswalks. Thank you, Angela. And that's what you're seeing here, which was from last year. We will have an updated document codification file very soon. Next slide. So this is just a comparison of ICD-10 and ICD-11. You'll see that Z coding is in ICD-10, ICD-11 might change. But that's years away from now. Next slide. SNOMED CT, for those who haven't heard of this, because you probably don't see this in your coding or billing, again, it's an ontology and it's concept-oriented, which means you can use free text and convert it to specific codes. You'll see it on the next slide, where there's a clinic where there's free text to code example. An example here would be a specific kind of pneumonia. And you'll see that the causative agent on the left is on the ontology in SNOMED. The disorder itself is broken down. The processes involved in pneumonia is broken down also on the right-hand side. Even the organism have their own specific codes when they do their lab test to see what organism is causing the pneumonia. So that's what SNOMED is. And why do we need this? You'll see it on the next few slides. Yeah, let's advance to the next one. Here we have free text that you see all the time by your providers or your physicians. In this case, a 44-year-old man complaining of chest pain and the lower back. And on the right side, you'll see that each of those specific concepts, age more than 40 years old, male, in pain in the lower back with a severity of 3 weeks, all have specific codes. And this is how your software and machines understand the concepts and of your data and how to aggregate them each other by using, again, a standard code. Next slide. And you will see a lot of social drivers of health data on SNOMED CT that is lost in granularity in ICD-10 Z codes. Another one is LOINC. LOINC, again, stands for Logical Observation Identifiers, Names, and Codes. Again, I mentioned earlier, there are LOINC questions and LOINC answers. Each PRAPARE LOINC question is bound to a LOINC answer question code, and each answer to those PRAPARE questions have a LOINC answer code on them. So if you want to query your database, you can just in a how do you say this, in a world where standards are being used properly by your vendor or the concepts are in the back end of your forms, then you can just put that specific LOINC code for the answer to PRAPARE for homelessness or food insecurity. You'll be able to get all of your patients with that specific answer to your PRAPARE question immediately. So that's the power of having those codes. And that's the power of not having your data in free text. Next slide. You'll see this is free for use again. The Meaningful Use program requires LOINC in lab testing, medical summaries, and sending data to cancer registries and public health agencies. Next slide. This is one of the most commonly used LOINC codes. You'll see creatinine, hemoglobin. You see a 5-digit code on the left with a check code after the dash. That's your LOINC code. Thanks. Next slide. So this is PRAPARE, and you're seeing this. You will see this on the LOINC website. 93025-5 is the one gold standard, or that's the one single LOINC code that represents the PRAPARE question, the whole PRAPARE questionnaire. And within that LOINC code, you'll see that personal characteristics, family and home, the second header or the second major headings have its own LOINC codes, as well as the questions have their own LOINC code. And if you drill down and click one of those questions, you will also see the LOINC and the LOINC codes for the actual answers. There are generic yes and no answers to these questions, which also conforms to how LOINC codes for that concept of an affirmative yes or a no or a negative no or even an unknown answer. Next slide. So we care about all of these. Are payers using LOINC codes? Great question. They should be. Especially because if they want to look at your screeners to see if they did it properly, sure. But right now, payers are more concerned about, again, ICD-10. What is the diagnosis? Is the Z code attached to that primary diagnosis? And if what is the CPT code for your provider encountering that patient during a regular E&M visit code, 15-minute code, 30-minute code, or is it a preventive medicine code? Yeah, they are focused on Z codes. You're absolutely right. But again, Z codes are not billable by themselves. They want us to see the primary diagnosis. And as we continue, again, the whole idea here is to make sure that the process of Z coding is happening in your health center. And if you're capturing PRAPARE data with the back end, having those codes in the back end, so that when you query your database, you won't get just regular free text with misspelled free text or wrong information or wrong data. It's really all about data quality when talking about standards as well. So care plans. This is kind of the workflow, how your data can work for you. When you see the health concern in the very top, you get the SDOH goal, for example, and what SDOH intervention or care activity you will be doing. And we always talk about it in the closed loop. How do you close the loop on social drivers of health? We want to take away much of the manual work that happens in addressing SDOH, positive SDOH screening, and loop that back so that your CBOs, your organizations who are those that are focused on that single or specific SDOH domains such as housing or food insecurity, they will use that one Z code to get all of that information and send back to your EHR that, yes, addressed this Z code, we have addressed this SDOH issue, it can be taken off the problem list. So stuff like that. That's the cornerstone of a care plan. And we are transitioning to a world where we are using what's called e-care plans, electronic care plans. We're letting our EHRs and our software do the care planning and closing all of that loops together. That will not work if data does not conform, again, to controlled terminologies and standard terminologies. Next slide. Especially in the world with AI, artificial intelligence uses a lot of coded concepts. And if you want to do risk stratification or machine learning on your SDOH data, on your PRAPARE data, you need to have them, all of those concepts coded using, again, LOINC or SNOMED or Z codes so that you can categorize them properly so that they are semantically not really equivalent, but semantically close at least. So this is the closed loop referral process that I was referring to earlier. We all talk about quality measures. We all talk about documentation and goals and assessment and surveys and whatnot. But again, if you do not know what's SNOMED CT, CPT, ICD, LOINC, all those stuff, you won't even be able to calculate your quality measures if your data is in free text. You'll have to get your analyst or a third-party vendor to do that work for you. And that's an additional work and additional burden to health center staff. If data conforms again to the standard, in the back end, your data is represented using the standard codes that all other health centers or healthcare organizations are using, then data can be easily aggregated and easily shared. Again, the important part here is sharing that data easily through our software and our EHRs or whatnot to CBO software or even registries. So next slide. So for those who are more tech savvy, there are application programming interfaces or APIs. And what you're seeing here on the very top would be your EHR collecting the data. Your payers are also collecting all of this data. And the idea is to use what's called the FHIR API. FHIR stands for Fast Healthcare Interoperability Resources. This is a human readable code that you can open either in XML or in JSON. You can open the file and you can actually understand the patient information from the code in FHIR. And that's what the FHIR API is here for. You can have your SDOH data and have them formed into FHIR, and that FHIR information or data that's represented on FHIR using FHIR can be sent to CBOs, care coordination platforms, right, or health information exchanges easily using FHIR. That is where the informaticists and your professionals are trying to do this API work. Again, so that you don't have to call the organization to refer patients. We're letting software do it for us. Next slide. So the VSAC, the FHIR API or VSAC, the Value Set Authority Center, that's where you will see different value sets for all social drivers of health domains. So if you go on VSAC and get the license, this is all free. You can get the value sets. Again, value sets are just groups of codes that represent one concept or a multitude of concepts to be used for computation or to be used to represent your data as long as the meaning is retained. The concept of the meaning of the concept is retained when you capture the data. Next slide. So for those interested in doing that kind of work, not just for social drivers of health, but also for other clinical concepts, such as if you want the value set for type 2 diabetes, you just want all of the codes for type 2 diabetes for your data work, go on VSAC, search for diabetes mellitus type 2. You will get a value set there containing all of those codes. For our purposes, for social drivers of health, there are value sets. The Gravity Project posts all of their value sets on VSAC. So if you need a value set by the Gravity Project, which, by the way, is the organization that has submitted SDOH data elements on US core data for interoperability, the Gravity Project's value sets are the ones referenced on US core, US CDI. Next slide. Yes, so these are the VSAC chronic conditions profiles on VSAC. So if you go on VSAC, you'll see they are split into 4: SDOH conditions, goals, service requests, and procedures. In this case, we are looking at conditions for those using the PRAPARE screener. You are using the SDOH chronic conditions value set to look at different health conditions, SDOH health conditions in their different domains. So yes, we have a NACHC and eClinical Works working group who we work with to make sure that the PRAPARE data elements are presented using the crosswalks that we have published. Thank you for the commentary on the chat. Thank you so much. You will see a lot of activities from your EHR vendor in using these codes in the back end, because again, the Office of the National Coordinator has an HTI1 proposed rule which mentions the mandatory use of USCDI version 3, so that all folks, all certified health IT products in the United States will have to conform to the how those data elements and data classes are represented using standard codes and terminologies, because we want a world where data is interoperable and usable across the whole spectrum of primary care, secondary care, and preventive care. Next slide. This is an example of SDOH conditions. You'll see the OID, the object identifier on the top, which identifies this value set. This is on VSAC, by the way. And this is a grouping value set, which contains a Z code, Z59.00, Z59, and .819 and above. You'll also see this grouped with SNOMED CT concepts. You'll see housing instability, finding in SNOMED CT, with more granularity than those using Z codes. Next slide. This is specifically for SDOH goals. This is not necessarily linked to PRAPARE, but this is these are the goals that you want linked to PRAPARE when they screen positive for example, food insecurity. If you want food security as a finding, that's on SNOMED CT. You'll see it on the very top, 1078229009. Food security as a finding. Next slide. We're kind of winding down, just showing you examples. This is a value set for SDOH service requests. So again, if you screen positive for and PRAPARE for a specific SDOH domain, what codes can your software use for service requests? You'll see here different referrals to psychiatric services, referrals to a clinic, referral to a social worker, assessment of progress towards goals to achieve food security. Again, these are not on ICD. These are on SNOMED CT. So ask your vendor, ask your HR vendor if they support SNOMED CT, if you want to do this kind of closed loop referral for really moving the needle on your SDOH assessments using PRAPARE. Next slide. Yes, great commentary here on the chat that you're seeing issues with PRAPARE on your EHR using NACHC. I highly suggest talking to your informaticist or your primary data person on staff to talk to your EHR vendor about all of these data issues that you are experiencing. And if you need more help with these, please send us an email or send me an email, rui@nac.com or informatics@nac.com, and we will help facilitate that conversation with you and NACHC or with eClinical Works or whoever your vendor is. Here you are seeing a value set for procedures on CPT codes. So these are CPT codes specifically for screening using a screening tool such as PRAPARE. So I hope you are using this 96161 and 96160 when you use an assessment tool to screen for different health risks, including social drivers of health. This is the two main primary CPT codes. Again, defer to your coding specialist for more information. Next slide. Again, the typical approach is the provider documents the issue and then talks to prescribes or talks to a social worker, and they are the primary people responsible for updating and maintaining it, which increases burden, as we understand, and I'm sure you guys are seeing that. On the next slide, you'll see kind of a better approach that we want using, again, data standards. So we want to transition from the typical approach to the next slide. A new approach where different concerns or different classes are in one row, kind of in like a waterfall type of project management approach, where different health concerns, including social concerns and medical concerns, are coded using those terminologies in the back end, those codes in the back end, and each of those codes is assigned to whoever are going to action on those codes using whatever software they are using again the care plan, hopefully using again SNOMED CT or whatever CPT coding you are using for the care plan. And the outcome is to loop that back into your primary EHR data so that the provider can see and make sure that different problems are being addressed. Again, not just medical issues, but also social issues. Next slide. Yes, so PRAPARE is predominantly completed by a community health center worker with a patient and might be completed outside of the visit. How would the organization account for that scenario? You would have probably some way of communicating that screening tool has been completed, and whatever positive screening that they get on the PRAPARE tool, maybe it can be handwritten. It really depends on how your workflow is done or how you communicate with your providers to make sure that they do that Z coding on there when they start doing their clinical documentation or their reserve hours for doing that documentation. So why bother and why do we care? Because again, typically Z codes are not reimbursable, and data collection is part and parcel for policy development. And you'll see on the next couple of slides, I know we're kind of winding that down. You'll see the current stats for Z coding is not too high. Next slide, please. Again, if we do not fix the quantity and the quality of SDOH data collection, even starting from Z coding, then we won't be able to see good statistics. We won't be able to do proper data-driven public health policies. And you're seeing this. Here's the latest CMS report on Z code usage. You're seeing that there is a modest, very small increase from 2016 to 2019, but it's still really, really low. We are seeing a change in proportion of Medicare fee-for-service beneficiaries with Z code claims. Only up to 1.59% of all Medicare FFS beneficiaries have Z code claims within that time period. You're seeing a 1.3 up to 1.59% only. Next slide. These are the top 5 Z codes we're seeing on all the claims, with Z59 homelessness topping at 22%, and the rest trailing at 12%. Problems related to living alone all the way down to 5%. Problems related to living in residential institutions or issues with relationships with spouse or partner. In the bottom, you'll see the 5 Z codes representing the largest share of all of those Z code claims. Next slide. Again, you can go to the CMS website to read the whole report, but I want to emphasize the very low proportion of Z coding. So California, congratulations, you're on the lead at 11% during the date of reporting at 2019, with Texas being second, Massachusetts, New York, and Pennsylvania around that percent also. We want to promote the Z coding, and I think we can do it from the software level, from the EHR level, and from really on that level. This will be required by law very soon in the proposed rule. But you should do some talking to your vendor or some liaison work right now to make sure that your PRAPARE form in the back end is using those standards. Whatever you choose, if you want a 1:1 Z code PRAPARE mapping or a specific SNOMED code PRAPARE mapping, as long as there is a terminology in the back end and as long as it's not in free text, your data analysts and informaticists will be able to operationalize those PRAPARE data that you are capturing using those codes. Next slide. Again, here would be the top 5 specialty codes being used for billing Z code claims, being topped by family practice. And this is really mostly primary care, right? Internal medicine, your NP, and psychiatry, and your licensed social workers leading the way. Next slide. Why bother and why do we care? Food insecurity, and we know a lot of SDOH information is really closely linked to chronic conditions and clinical care and clinical diagnoses. 1 in 4 adults, for example, have advanced CKD or chronic kidney disease. One out of 4 are food insecure, either without hunger, moderate, or severe hunger. And coding for that Z59.4, lack of adequate food and safe drinking water, for reporting these will be very important to actually help that person address their CKD or chronic kidney disease. As you know, this is a major killer and it's a major burden on our health system for CKD patients to undergo dialysis, and the frequency of that dialysis is really contributes to a lot of burden, not just for the patient, but for the family caring for that patient. And this is just one of a very long list of examples of why SDOH coding is important, so that this type of analysis can be done and can be published in research and can be presented to leadership, so that we can champion policies and champion software connections, so that the work that we are doing is, in the 21st century way, that we do buying stuff on Amazon or shopping and all of our media content that makes a lot of money. In this sense, we want to operationalize SDOH data so that we can deliver proper care to those patients that we know are in need. Next slide. Again, I welcome everyone in the group here, all of our participants, to join us in really talking to our data folks and submitting new codes, or checking to see if you are capturing, and talking to your vendor, make sure that the data is being captured the right way, or they're confirming to regulation, or they're confirming to the Gravity Project's recommendations. Those are the things we need from you guys. And for the technical folks, on the next slide, welcome you to contribute to the technical fireside. Again, I guess in this slide, for those who are non-technical, who really are experts in the SDOH domain and have a really intimate relationship with the data and know their patients and know their patient populations, please collaborate with us with the Gravity Project so that you can propose new SNOMED codes or new LOIN codes that for different SDOH situations you're seeing in your patient population. Next slide. I think we're winding out. We're almost at the end. Again, we want to accelerate the adoption of nationally recognized standards, starting from the diagnosis of SDOH to goal setting to SDOH interventions, and again, from the very beginning, actually screening and assessing patients for SDOH and using
Ray, are you still here? Give me 1 second, everyone, as Ray's currently having technical difficulties.
the slide presentation again.
Yeah, sure.
Chloe, thank you so much.
Sure.
Thank you for your patience, everyone. So yes, thank you so much again. As a reminder, the codification file is presently there, and this will be updated very soon. So thank you for your patience. Next couple of slides, Chloe. Yes, so let's transition to Q&A. We have 6 minutes. I want to answer a question by Jennifer. Thank you for your question. For those health centers that do not have any data or IT or tech staff, what is the recommendation for the health center controlled network to support these centers? You are okay, I see. So there are some HECNs that do not have an informatician on staff. If for those cases, what I would recommend is for you guys to reach out to us here at NACC. So we have staff on staff, myself and our CMIO, Dr. Julius Capik. We will be able to help facilitate that conversation with you guys and your vendor it can be your third-party data reporting vendor or their actual EHR vendor that your health centers are using, we can definitely open that conversation with them so that your health centers will not be affected by any of the ongoing or the currently proposed health IT ruling that is proposed to come into effect before the end of the year 2025. Again, I think the most important keywords here is US core data for interoperability, or USCDI. Again, those are data elements that your vendor will have to conform to if they are certified health IT products here in the United States. Chloe, are there any questions that I missed?
No, it looks like you got everything, Ray. I'm not sure if folks have any additional questions for Ray.
I am doing some back reading. Again, thank you so much for your participation in the chat. I think one of the more common questions again that get asked during these sessions is really billing or reimbursement. Again, I want to reiterate, Z codes cannot exist by themselves. Unfortunately, there has to be usually a primary diagnosis that comes along with a Z code when you submit your claim. That's it. So when linking again data, the primary message here for everyone, may you be technical or non-technical on the staff, is to start that conversation for any of your tech folks on staff. Have that line, that communications line with your EHR vendor or whoever is your vendor that is managing your software, and ask them, are we recording our SDOH data? Are we capturing PRAPARE data in free text? Or are we capturing PRAPARE data using the LOINC codes that they are supposed to be represented as, or any of the mapping, or are they using any of the standard codes from the cross documentation or coding document on the PRAPARE website? Are any of those being used in the backend? That is one of the first questions you should ask. So there's a question here. Can you please elaborate the single line code that encompasses all the questions in PRAPARE screening? Okay, let me clarify that, Anu. So that 93025-5 is the line code that points to the full PRAPARE question, but it does not represent the individual questions and answers in PRAPARE. So if you were to query your database for LOINC 93025-5, you will probably get a list of patients who have data probably, or with that PRAPARE questionnaire has been launched or has information on it. Whether so it really depends on your data model or how your database is set up, but definitely check that out.
So it those are fun, but it you gotta be careful because I got up real close to the fifth, and I'm like, oh God.
There's also a question, Angela, thank you so much. Vendor templates have the Z codes built in. However, if a non-provider staff is using the template outside of the billable encounter, how does information flow to the problem list? Yes, this is a very tricky question. That's because even though, like I said, anyone in any health center staff can administer PRAPARE, but really the Z codes that need to be, before they can really be put in the record, it has to still be a provider on staff, a licensed provider, so that you don't guys get in trouble. I think that my biggest recommendation is try to look at your workflow and try to find a way that this is communicated to your providers. I know this is kind of a low-tech type of thing because we're still trying to promote the use of the standards, right? So that this is it easily pops up in the interface for your providers to see, or suggested SDOH coding or suggested Z codes in the problem list. This question really depends on the vendor that you're using, and your ability to customize and to ask questions. Yes, this is again really tricky. That information does need to go to the provider. So find the communications line to do that for now. And we together as a community will work on automating these processes and really tweaking them to reduce that this workflow, Angela, that you have been referring to, that I'm sure a lot of health centers are experiencing about. Yes, we know that food insecurity needs to be in the record, but I need to bother the provider to actually sit down and put it on the problem list. And I know that takes away from, the time of care. The providers may not be trained about the importance of Z coding and might not really care so much. So those are really big issues that need to be tackled. So great questions. Yes. Yes, we have vendor working groups, Angela. It is sometimes tricky to work with vendors. As you know, they have their own agenda as well. And that's why we are approaching this from the regulatory perspective. Again, working with HRSA and working with the Office of the National Coordinator for Health IT, and really being the voice for you guys in promoting the SDOH data elements on USCDI starting version 2 and onwards. Again, I'm inviting everyone, please collaborate with us. It's called the Gravity Project. Just type it on Google, Gravity Project. And those are folks who are doing the coding and billing and changes for that is going to be required again. So yes, thank you so much for your everyone's participation. We are at the top of the hour. Please send me an email, and please send the our awesome NACC Prepare folks an email if you have any questions. We are here to help you guys. You are not alone in this journey. And that's it. Thank you so much. My name is Raymonde Uy. Thank you for the NACC Prepare staff, Chloe, Nalani, Yuriko, and everybody else. Thank you for your time, and happy Monday, everyone.
Thank you everyone for joining us, and thank you, Ray, for that amazing presentation. We will have these session materials. We will send that out to you all again in our follow-up email, and the session was also recorded, so if you would like to share it with a colleague, please feel free to do so. We will upload it to our YouTube channel, so we will follow up with all of that. But with that being said, thank you everyone for joining us. Have a wonderful afternoon. If you have any questions, please feel free to reach out to us, prepare@nacc.org. I will go ahead and drop it in the chat for you all. And Ray also dropped his email in the chat. So if you have any, thank you, Ray, you dropped both of them. So thank you everyone for joining us, and have a wonderful afternoon.
Thanks, Chloe. Thanks, everyone.
Thank you. Have a great one. Bye.